The topic that I am going to talk on is damage control orthopedics. For the postgraduates among you, it will be something that could be asked in your theory or sometimes in your viva, etc. But more than all that, it's a practical problem when it comes to management. That is mainly because today we know the trauma is increasing and we have a lot of polytrauma patients, and the management of a polytrauma patient has got many problems in doing what is first, prioritization. And definitely most of us prefer to finish off everything in one sitting, what is called the early total care. We prefer to fix all the fractures in one sitting because it makes us an efficient use of our operating system, theatre and the personnel. And also once we fix the fractures, the patient is much easier for looking after the other injuries to the patient, for the further test and for other problems too. So this is what is called the early trauma care. This became popular in somewhere between the 80s to 90s. There were many articles showing very good results with the early total care. One of them was from the Dr. Lawrence Bone. The principle of early total care was fix the long bone fractures within 24 hours, resuscitate aggressively. That was the main theme behind it. And this article showed that early definitive surgery or ETC was shown to decrease late complications. Now just think of a scenario before we go to the talk. This was a young adult who came with the RTA with a bilateral fractured femur. The other side is not seen in your X-ray. What is important here, you can see the dislocation of the right hip. He had a chest contusion. He had a loss of consciousness but nothing else to suggest head injury. Vitals were stable. The hip dislocation gave us the priority. So the tendency was for early trauma total care. The same day nailing of both femur and reduction of the hip was done. Fortunately, the hip came by close reduction, you can see that. But the story didn't end. 4 days later, he had a florid ARDS. You can see the X-ray, and of course the picture of the lung is not his, that is from the net. The ARDS was fatal, out of the confirmed ARDS. Now the question remains, if probably we did not do early total care, if we had gone for another alternative, would it not happen, or would you have still had the same result? That is the question between early total care versus a damage control orthopedics. What is the evidence-based answer for the question will come in the end. So between early total care and damage control orthopedics, now what do? We know that there are several situations in which you cannot fix the fractures in early sitting, particularly when the patient is unstable, when he is in hypotension, when he is in hypoxia. All these things you cannot do a early total care, and that is an indication for a damage control orthopedics or DCO. Now before we go into that, we know that what is damage control orthopedics. We know that today one of the commonest disease, if we can call it like that, is trauma. And most of these long bone fractures like femur, they need surgery. So if I can't do early total care, what can I do? How much can I do? When can I do? How I can do? That is a damage control orthopedics. Now how did it start? When in the 80s to 90s, when early total care was becoming promising, that time there was an article in 1990 by Border and Group where they found that in patients who had some blunt trauma, this actually came early from damage control surgery. They found that when you do not go for an immediate fixation of femoral fracture, the results were better. But in that time, still early total care was performed in more hospitals, more centers. And following 90, there were many articles. I am not going to that because of lack of time. Most of them showed that there was physiological problems following intramedullary nailing. And these problems, what effects you have, a systemic physiological problems, they were called as second hit phenomenon. So there came the physiological basis for damage control orthopedics. That's a huge topic. I cannot go into that. I have given the references below. You can read them. There are very good articles. So the main concept was As I told you, this came from the general trauma surgeons. They found that if you just do a quick laparotomy, control bleeding and pack off and do surgery later, it was good. This same principle was applied to trauma, and again it was found that in a femoral fractures you can probably stabilize the fracture by external fixation and then do an internal fixation later. The results were better. That was the beginning of a damage control orthopedics. This was later justified by many studies which led to the theory of second hit phenomenon, or what they call the two hit hypothesis. The main reason for this was SIRS, or a systemic inflammatory response syndrome. Again, that is a huge topic. You'll have to probably read up in the article which I show you next. But the main concept was there is a response of the body to trauma, and this response is in the form of releasing of some systemic inflammatory response which will lead to these mediators, inflammatory mediators, cause physiological changes that leads to the second hit phenomenon. What are these? That most important thing, the nailing has been shown that it is a systemic insult that is large enough to fill the role of a second hit. Unfortunately, most of us like to do a nailing for femur, and that nailing unfortunately has been shown to be something which can cause a second hit phenomenon. There are many articles supporting this. So the main reason is the primary inflammatory mediators. So this includes interleukin 6 and so many others. You can see in this instructional course lecture in JBJS in 2005, excellent article you can give. They gives all the details about the various inflammatory mediators, which I am not going to go. But what is important is that if you do a surgical procedure, when these inflammatory mediators are already there and your surgery causes a second hit phenomenon, then the patient can be pushed towards a multi-system organ failure, and these mediators, they remain in the body for something around 5 days. So approximately that is the time when you have to avoid your surgery to avoid a second hit phenomenon. So in principle, what does DCO mean? It means that you avoid provoking a severe inflammatory response. So the idea is that you do not do surgery which are going to create a second hit. You do surgery where you just stabilize the fractures to prevent further tissue damage, prevent the possibility of compartment syndrome, and allow the patient to be mobilized for general care and various tests what are necessary. This stabilization of fractures are comparatively simple. If you are thinking of upper limb, you can do a splinting or a sling will be enough. Even for fractures below the knee, again there are splinting will be enough. But unfortunately for fracture femur, that is not so easy. For fracture femur, yes, traction alone or traction or splinting will not be possible. There you will need external fixation, and fortunately that does not cause that much blood loss or not invasive enough to act as a second hit. The next question is, when do you go from this external fixation to internal fixation? As I said earlier, it takes about 5 days for the interleukin levels to decline. So any definite repair should be preferably done within 14 days. And if you take this article in 2006 Journal of Orthopaedic Trauma, it says that if you do a nailing within 14 days, there is no increased risk of infection. So the window of opportunity for the femur lies somewhere between 5 to 14 days. And within this 14 days, you can do an alternate treatment. But even after 14 days, the patient is not fit for a surgery which make a second hit, then probably you have to think of alternative methods. Now, this is not the only scenario. I'll just quickly mention the other scenarios. Long bone fractures or femoral fractures are not the only scenario where you have to think of a DCO instead of ATC. Maybe a patient with a head injury. Even with a head injury where there's already a raised intracranial pressure, if there is a second hit phenomenon, if there are inflammatory mediators, patient may go for hypotension, hypoxia and more brain damage. And similar thing also in a local and a soft tissue damage. If you have probably even a closed fracture with a soft tissue damage or an open fracture with soft tissue damage, there also probably you might have the same problem of the second hit phenomenon. Even there, the principle of external fixation stabilizing the fracture and later going for a definitive surgery will work. Sorry. I just go fast because time is going up. So when do you do a early stabilization be delayed? When do you go for a DCO? When the patient is probably hypotensive, when there are coagulopathies, when they have hypothermic, when there is traumatic injury, when there is significant vascular injury. In other words, where the patient is still unstable. Advantages already said, there is a minimal systemic insult, and there are other advantages that you are able to do your second job in a better situation. So the principles of DCO is that you do a reconstruction and the best situation for you and also best situation for the patient. But the answer does not end. Is probably the DCO the only answer? No, there are still areas of damage, like ETC came with a bang, then the DCO came. There are some areas where many questions are not answered. Most of the articles end up by saying that you need a large, just 1 minute more, a large prospective studies to give an answer if it is an evidence-based answer. But is it really ethical to recruit these patients for study? Is it practically possible to recruit such severe injury for any kind of a study? That is something which is very controversial. Even now, early total care is practiced in most trauma centers. What is important is that you have to optimize the clinical assessment, provide careful monitoring and do an appropriate resuscitation. But when these are not possible, probably damage control orthopedics is the best option. For example, if there is a patient who cannot be resuscitated, patient is hypotensive, then probably do an emergency X-fix and then later go for definitive surgery. The same thing applies to institutions that do not have adequate infrastructure for managing a polytrauma, and there probably the safest is to do a DCO and transfer to an appropriate place. Just the last few slides. So if the first question I asked for the patient which I had, should I have nailed him or not? Now we look at the recommendations. This is again from Evidence-Based Orthopaedics, a textbook, with 2009 edition. If you have an adult with multiple trauma injuries, should he undergo femur fracture within 24 hours? There is a level B evidence. Or in that situation, is a reamed nail better than a unreamed nail or equally safe? Again, there is a level B evidence. But you come to the $1 million question, is there evidence to say that ECO is better or worse than a DCO, ETC is better than a DCO, or is early fixation worse or better than a damage control orthopedics? Unfortunately, the level of evidence is inadequate. In other words, today there is no evidence-based answer to say that damage control orthopedic works. And interestingly, the Lawrence Bone, he was one of the pioneers of the early total surgery, showing better results. This article from him in the February of last year, and this is actually on femoral fracture fixation with the chest injury, and this is the algorithm he has given. So if you consider my patient who had a bilateral femur fracture, if you see there in the same article, if the fracture femur, if he had a chest injury, but if he was stable and if he was not having an injury score more than 35, then he was fit for early total care. So probably if you follow this article, still probably I was right in doing an early total care for the patient. But is that the answer? Probably no. If I am going to summarize, probably damage control orthopedics is very important for management of polytrauma. It has definitely improved the patient care from systemic, neurologic, other problems. But as of today, whatever DCO protocol, it makes very good theoretical sense, but there is no prospective data. And we probably need additional studies before we say that the DCO protocols can be universally accepted. As of now, there is no evidence-based data. So the real decision comes on an individual case basis. Before I close, I just want to inform you about a teaching program that I am planning in July 28 and 29 at Pondicherry. Last year we have good faculty for you. Details you can ask me later. Thank you very much.